Hello, everyone. My name is Ana Alcalde. I'm from Asunción, Paraguay. I'm a pediatric fellow and at the Institute of Tropical Medicine, where this patient was admitted. This is an hospital specialized in infectology. I would like to start mentioning how challenging this case was, given the fact that the patient was admitted with very atypical symptoms. This is a 6-year-old female patient who came for a painless left submaxillary swelling of 3 weeks evolutions, fever for 1 week, and joint pain in the metatarsal joints. The patient also had remote history of repeated epistaxis with spontaneous resolution. At physical examinations, and only 3 alterations were revealed. We can see in the image submaxillary swelling initially without inflammatory signs. During hospitalizations, the swelling increased in size and became painful. Also, a mouth ulcer and an ecchymosis on knees. During hospitalization, the patient persistent febrile with inflammatory signs and in the elbows and knees and revealed malar erythema. Initially, we thought of an infectious process with poor response to antibiotic therapy. But then because of the persistent dyscrasia and anemia and the history of repeated epistaxis, also because of the clinic of the patient with fever, joint pain, and ecchymosis, an hematological and an immunological disorder were studied. The results are in the table: antinuclear antibody positive, anticardiolipin positive, dyscrasia sanguinea, factor II deficiency, and lupus anticoagulant positive. About diagnosis testing, initially we only had anemia and dyscrasia sanguinea. So how do we get to the final diagnosis? During hospitalization, the patient finally exposed other alterations at the laboratory testings, and she exposed pancytopenia, hypofibrinogenemia, elevated liver enzymes, elevated acute phase reactants, and hypertriglyceridemia. Ultrasound showed pleural and pericardiac effusions and heterogeneous hypogenic structures in the submaxillary region. Finally, a puncture confirmed an hematoma as the cause of the submaxillary swelling. All cultures taken in the patients were negative: blood, urine, and punctured hematoma. A bone marrow aspiration was normal, so other hematological or immunological disorders were ruled out. All this together leads us to the final diagnosis of juvenile systemic lupus erythematosus, debut with a deficiency of factor II coagulation and macrophage activation syndrome. Initially, broad-spectrum antibiotics was started, but when a final diagnosis was made, she received boluses of methylprednisolone, immunoglobulin, and hydroxychloroquine. Due to dyscrasia, she received vitamin K, transfusion of fresh frozen plasma, and 1 transfusion of concentrated red blood cells. With all this treatment, the patient had a good response and favorable evolution. So a summary, and we can see in this case, a typical hematological manifestation may be the disease onset in juvenile systemic lupus erythematosus. Epistaxis and blood dyscrasia were the guiding elements for the diagnosis and clinical management of this patient, and most occurs in juvenile systemic lupus erythematosus, mainly during periods of disease activity as at clinical onset in this case. Thank you very much.